Hello, welcome to the channel. We want to today look at tuberculosis and the drugs that we use to manage tuberculosis. So we've been dealing with bacteria. Now we want to talk about some atypical bacteria species. So tuberculosis is one example of our atypical bacterial disease group. The main causative organism for tuberculosis in man is mycobacterium tuberculosis. This is the one that causes mostly tuberculosis in men. But there are others also that have been associated with tuberculosis. For example, Mycobacterium africanum 1 and 2 have been associated with pulmonary tuberculosis, also usually referred as PTB in Africa, especially the West Africa. Mycobacterium kansasi is also one that has been identified with tuberculosis in men. Mycobacterium bovis normally causes tuberculosis in dogs, but it can also be seen in men. Mycobacterium microti and Mycobacterium malmoense are also seen to be causes of tuberculosis. So the point here is that various mycobacterium causes tuberculosis. But the most common or the main cause in human is the mycobacterium tuberculosis. Infection with these mycobacterium can occur in any part of the body. TB can occur in any part of the body. But the most common site is the lungs, which is what we call pulmonary tuberculosis or PTB. Now, if it occurs in any other part of the body, apart from the lungs, it is referred to as extrapulmonary TB. Extrapulmonary TB. So other sites that you can have the infection includes the spine, the bone, the joints, the brain, the abdomen, the urinary tract. Is an infection, so it can occur in any part of the body. And normally it's been shown that people whose immune system has been compromised one way or the other are the ones who are less resistant to the infection, in other words, more susceptible to the infection. So HIV patients, diabetic patients, pregnant women who, because of the pregnancy, have their immune system adjusted just to sustain the pregnancy. So and then of course, abuses of certain drugs like steroids. Tuberculosis comes with certain symptoms that we use in identifying. Of course, we have to do a lab to confirm, but at least these symptoms point you to the fact that you should make investigation in finding out if there is TB or there is that infection in a patient you are dealing with. So if you had someone who's been coughing for more than 2 weeks, you must investigate. Or someone who has chest pain, and the symptoms are usually in combination, not only one, but one should be enough to trigger your curiosity to do the investigation. Unexplained loss of weight or loss of appetite. The classical sign is blood in sputum. Hemoptysis. If you see blood in sputum, it points you to tuberculosis. In children, you will see all these adult symptoms, plus also sometimes you see malnourishment, and the children are almost always looking ill. Chronically, anytime you see them, they are looking ill. What is called cachexia. So these children fail to thrive. They are always irritable or restless. And in the case of TB infection in the meninges, these people could be unconscious or their consciousness could be impaired and they come in with vomit. Fortunately, tuberculosis can be treated. There are two management methods that we have, and this is dependent on the type of tuberculosis that we are dealing with. So basically, there are two types of regimen that's available for management of tuberculosis. We have the standard treatment regimen for newly diagnosed patients. That means patients who have never had tuberculosis and are freshly diagnosed with the condition. It could be that their lab shows a smear positive or a smear negative presence of the bacterium, the mycobacterium. And it could also be pulmonary TB or extrapulmonary TB. But as long as the diagnosis has been made and it is a newly diagnosed case, we manage the condition using primarily 4 drugs in the initial state and 2 drugs in the continuous phase. The combination of the initial phase, the continuous phase, gives us 6 months of treatment. So the treatment category 1, which is what this standard treatment regimen for newly diagnosed patients is referred to, treatment category 1, consists of 6 months of therapy or 6 months course of treatment. Now, we should understand that in tuberculosis, when we say a month, we mean 28 days. So basically, we're saying it consists of 28 times 6 days. In the initial phase, the first 2 months, which is also the intensive phase, the phase where we radically want to suppress the tuberculosis, prevent reinfection to others, etc., we attack with 4 antibiotics, what I have referred to as RIPE, as my way of easily remembering: rifampicin, isoniazid, pyrazinamide, and ethambutol. Now, because we are doing 2 months of this first or initial phase, that's why we have 2 times 28, which is a month, so 2 months, and we have 56 doses, as you can see over there. Tuberculosis is to be managed on DOT. That means directly observed therapy. That means your patient is supposed to be taking the medication in the presence of the health caregiver, so that you observe that they are taking the therapy. Now, after the first phase, the initial phase of 2 months, 2 of the antibiotics are dropped. The last 2, pyrazinamide and ethambutol, are dropped, whilst we continue with rifampicin and isoniazid, the strongest of our antibiotics among the list. So this continuous phase is also 4 months, which means 4 times 28 doses. And that is the 112 doses, as you see over there. So that is where we are using standard treatment category 1 and 3 for newly diagnosed patients. The second group of patients that we also give management to are those who have been previously treated. We call them previously treated patients or previously exposed patients. In this case, these are patients who either they got treated and they've gotten the condition back, what is referred to as relapse, or whilst they were on treatment, they did not adhere to the course and therefore interrupted the treatment one way or the other. Or they actually took the full course of therapy and yet the treatment failed. All these will be referred to as previously treated patients, and they will be given the second type of medication or the second course of medication. It's basically adding 1 month to the initial course of therapy for the category 1 and 3 and adding 1 month to the continuous phase. So for those who have been previously treated, the course now increases to 8 months, 3 months of initial phase and 5 months of continuous phase. Second thing we do is that we also add 1 medication to both phases. The initial phase, we add 1 medication. The continuous phase, we add 1 medication. So in the initial phase, we now use RIPES. So the S is the new introduced medication. Rifampicin, isoniazid, pyrazinamide, ethambutol. Then the new introduced product is streptomycin, an aminoglycoside. Then in the continuous phase of 5 months, rifampicin, isoniazid is maintained and ethambutol is now added among the list. We should note that this also is done under DOT, once daily under DOT, directly observed therapy. This category or this regimen is referred to as the category 2 regimen. Note that when it comes to the initial phase, streptomycin is the only injectable group among them. Every other medication, as we're talking about, is an oral medication, but streptomycin is an injection, and it is given for 2 months instead of the full 3-month course. It is given for 2 months. So after the 2 months, you will be left with RIPE, which you will continue to the end of the month, and then you now drop pyrazinamide. And you now have your rifampicin, isoniazid, ethambutol. 3-month course becomes 3 times 28, which is 84 doses, as we can see, for the RIPE. But because streptomycin is doing 2 months, 2 times 28, that gives us the 56 doses. Here are some important things to note. If you are giving rifampicin, it is known to color body fluids. So your patient should be aware that the drug they are taking could color or change their body fluids. So their tear, saliva, sweat, urine, etc. would change in color, change to reddish sometimes in color. The patient should be aware that this can happen potentially with the drug, and therefore when they see it, it is from the drug. The next thing important to note is that if we're going to use isoniazid for a long period, it is known to cause peripheral neuropathy. And therefore, it's very important that we prevent peripheral neuropathy when we are going to use isoniazid. And as a way to do that, we give vitamin B6 pyridoxine. 25 milligrams of pyridoxine is used prophylactically to prevent peripheral neuropathy being caused by isoniazid. So that means an additional drug, a vitamin B6, is added for prophylactic purposes. And for our HIV brethren, you double the dose from 25 to 50 milligrams because they have an increased, a higher risk of that neuropathy. So a doubled dose for the prevention. The next thing we want to note is that in pregnant women and breastfeeding women, aminoglycosides, which is the streptomycin, are supposed to be avoided because they cause teratogenicity They affect the unborn fetus, cause malformation, etc. They can cause ototoxicity in the neonates as well as even in the adults. So they are supposed to be avoided in pregnant women and breastfeeding mothers. We do not use streptomycin in breastfeeding or pregnant women. So we note those important points. Sometimes we have resistance developing whilst we are using these medications. We have what is known as the multi-drug resistant tuberculosis. Now, we describe tuberculosis as a multi-drug or a bacteria as a multi-drug tuberculosis bacteria if it is able to resist at least one of the two most powerful antibiotics we are using, isoniazid and or rifampicin, sometimes referred to as rifampin. These are the two most potent TB drugs we have. And if the bacteria is able to develop resistance to any of them or both of them, we describe that bacteria as multi-drug resistant tuberculosis. In such a situation, experts, specialists are supposed to be consulted for the management of the patient. Now, normally, like all resistance, it can occur if we mismanage the TB drugs we are using, or we misuse the TB drugs we are using. For example, the interruption that we mentioned for previously treated patient, not completing the medication as it's supposed to, or interrupting the medication in the course of therapy, all can contribute. So some of the ways we misuse or mismanage medications is where we are not completing the full course of the treatment, or where the healthcare provider provides the wrong treatment, wrong dose, wrong length of time. And in this instance, it could be not using the weight, etc., etc. Or where drugs that should be used for proper treatment are not available, and therefore there's improvisation, which results in resistance. Or the drugs that came in are of poor quality. These can all contribute, and that is examples of what we mean by misuse and mismanagement of tuberculosis medications. And that also cut across for all antibiotics and antimicrobials, we should put it that way. People who do not take their drug regularly are among those we see drug-resistant TB commonly. People who also do not take all of their drugs also are among those who give us drug-resistant TB. People who have developed the disease again, a relapse, even though they've been treated in the past, are also among those who are common to develop drug-resistant TB. And people who find themselves in areas where TB-resistant strains are common, or people who have spent some time with someone who already has the drug-resistant TB, because it can be transferred from person to person. All right. So the FDA categorizes our TB medications thus. Pyridoxine, which is the B6, is category A. Rifampicin, isoniazid, pyrazinamide, ethambutol, the right, is categorized as C, and streptomycin categorized as D. should be avoided in pregnancy. Thank you very much for your time. The Lord richly bless us all. Please don't forget to subscribe to the channel for more videos. God bless.